Hello and welcome to this Wound Care Today Facebook Live seminar. Thank you for joining me. My name is Helen Shoker and I'm an independent nurse consultant. My background is a tissue viability consultant nurse in the NHS, where I worked across an acute sector. I then moved into nurse leadership positions, ultimately as an executive director of nursing for a small specialist trust. I'm here tonight to share with you our thoughts, and I hope that you will add your thoughts to the screen as we go along. Today we're looking at pressure ulcers. In particular, we're going to be exploring when is good enough. This seminar is supported by Mernlicher, and contact information will be available at the end of the presentation. At any time during the seminar, you can submit a question, and we welcome you to do so by commenting on the video. And we will do our best to answer as many of your questions as possible at the end of the presentation. After the event, you can access your certificate of attendance, which will contribute towards your revalidation and CPD hours. We'll now move on to the presentation entitled Managing Pressure Ulcers, When is Good Enough? I'd like to start by just saying please excuse me if I start to cough. I've got the virus that I think is spreading around the country, and also my nerves are probably kicking in a little bit now. So if I need to cough, I'm going to just turn away so that I don't do it in front of you. So let's move on. Managing pressure ulcers. When is good enough? We're going to explore the challenges together, and I'm going to deliberately challenge you in your own understanding. What does it take to be outstanding in pressure ulcer prevention? My aim tonight is to provoke you, but in a positive way, to ask questions of yourself, your team, your service, and your organisation. So I hope that you will be with me through this. Our learning objectives might be a little bit different for you tonight, in that we're not going to be covering the etiology of pressure ulcers, nor are we going to be talking about the assessment or the classification of pressure ulcers, nor the risk of pressure ulcers to patients, but rather we're going to reflect on the current fundamentals of pressure ulcer prevention, what is the value of pressure ulcer monitoring. We're going to consider the current measures of pressure ulcer occurrence, and we're going to explore a little bit pressure ulcer governance and what it means to be assured versus reassured about the incidence of ulcers. We're also going to explore when is good enough, and the value of that within quality improvement. And finally, together, we will share our learning through a question and answer session. So what are our current fundamentals of pressure ulcer prevention? Well, it has to start with our patients, that we undertake with them a holistic risk assessment, and that risk assessment is done in a timely way so that we can then plan our care and deliver appropriate care to those risk factors from the point of the patient entering our care. It's important that we think about underlying etiology. What's the past medical history that our patient is bringing to us today? What disease processes may be affecting their risk of pressure ulcer development? How mobile are they? Can they move about in their bed and their chair? Can they walk from one place to another in the room? But importantly, it's that bed-chair situation that we need to think about. Are they able to change position and move from side to side? Are they able to stand unaided or with simple aids from a chair? What kind of pressure reduction are we going to provide as a result of their mobility standards levels? So do we need to think about what their seating is like, what their mattress is, their bed frames, etc. How are they eating and drinking? So what are our nutritional and hydration assessment tools telling us about how we need to support their nutrition and hydration so that their skin can be as healthy and as resilient as possible? Another areas are prescribed medication. Many of the things that we give patients with very good intentions to help with one underlying etiology or medical condition can also have a negative impact on the risk of pressure ulcer development. So it's important that we consider what those risks are. And once we've done that, it's important that we go back to reassess our patients at regular intervals. That reassessment can give us reassurance that the care that we're delivering is appropriate to the patient for that point in time. One of the areas that I've seen challenges in my own career is about the consistency of care, and that a really good risk assessment can have been done, a really good plan of care can be put in place, but for a whole range of reasons, that consistency of care deliver fails our patients. So how do we make sure as a team we deliver the consistent care that is based on assessment and risk factors? Within England, and I am just speaking about England today as that is my experience, but I do recognise that we have colleagues joining us from Scotland, Northern Ireland and Wales, and I hope that what we're talking about will resonate with them too. So within England, back in 2015 to 2016, NHS England undertook a change in the monitoring of pressure ulcers, and it became mandatory for every acute hospital provider to provide this data. During that time frame, just over 24,000 patients were seen to develop new pressure ulcers. And of those patients in those acute hospital beds, the hospital length of stay was 25 days. So let's just think about that. We know from all of the research and the documentation that pressure ulcers are avoidable. We know that they are a costly harm. But importantly, it's the harm that's caused to patients. And in more recent years, with the increased awareness of sepsis, the avoidable issues of sepsis surrounding that. So those 24,674 patients all suffered harm that could be avoidable. And we need to bear that in mind as we carry on through this evening. So some might think it's a mountain to climb because we've got a number of patients, but also when we think about that 24,000 patients in comparison to the number of patients that are seen in the NHS every single year, it might seem that actually pressure ulcers are a lower importance to our organisations, and that might make that mountain that bit harder to climb. But every mountaineer will tell you that it isn't just about them climbing up the mountain. It's about everybody in the team at the different camps all the way through the mountain to get to the pinnacle. And that's what we're going to explore this evening. Back in 2016, a national programme was launched to create a culture shift in all care settings, and it's called the Stop the Pressure campaign. You can find information about this on the campaign website, where it has lots of examples of partnership working and improvements that have been made in real life practice, and I encourage you to go and check out that website. The main focus of this was about that culture change, something that is not seen by the whole organisation, that perhaps isn't recognised by the whole organisation beyond link nurses, people that are interested, and tissue viability nurses. So it was about starting the conversation about how do we prevent, not just how many do we count, but how many we can prevent. I'd like to take a few moments now for us to share some examples from the sporting world to demonstrate how we can move forward. This is Kip Shock. He's a marathon runner, and in autumn 2019, this autumn, he was the first runner to break the 2-hour barrier for the marathon. And he was quoted as saying, "Anything is possible." Why did he do that? Why was the 2-hour barrier something so important? Well, it showed a real ability to acknowledge that actually you could push further, that something is good, it's a great result, but actually you can go to the next level of outstanding. He was reported as saying that his success was as much about the approach that they took to doing this and the team around him as it was about him as an athlete and an individual. They had great technical support, and the pace-setting team was made up of world-class marathon runners and Olympians who were all dedicated to supporting him to break the 2-hour barrier. Interestingly, though, is that it wasn't a world record because it wasn't actually a competitive event. And so their challenge is to move through that 2-hour barrier in an actual marathon that is a competitive event. So just think now about how that applies and how his passion for doing something even better would apply to your clinical practice. About the fact that it wasn't about him as an individual athlete, but about the team that was surrounding him to help him to get across the barrier of 2 hours. And that they needed technical help to actually help them get there. The next one I love. This lady is known as Spider Woman and said her favourite hobby as a child was climbing trees. She's Indonesia's Aris Susanti, and earlier this year she broke the women's speed climbing record. She climbed up 15 metres in 6.9 seconds. It just amazes me how fast she went up. Go online and watch the video. And how did she attribute her success in doing that? Because it's super fast. Well, she attributed it to the fact that she knew what she wanted to achieve and that she was only going to do it bit by bit, chipping away slowly and surely, showing improvement through the smallest changes to achieve the result of beating the record. I do encourage you to look. So how do we move from a position that might be good already? Well, innovation is our key to doing that. So we're going to spend a few moments looking at innovation. Let's start with our pressure ulcer fundamentals. That's the starting point. So when we're thinking about how we are doing currently, many of us will use, or most of us I would guess, would use root cause analysis and will use incident reporting. So a patient is admitted to our care, whatever the setting is, and they develop pressure ulcer. We look then at all of the various things that may have gone into them developing an ulcer, and we report it through our incident system. And there are elements of safeguarding within that. That root cause analysis will show us what themes have emerged from the reasons why the patient has developed the pressure ulcer. And it's really important that that root cause analysis is a holistic analysis that encompasses not just the patient, but the setting, the staffing that were on duty, the environment that they were cared for, and the equipment in place. So thinking about the staffing levels, did you have the right number of staff with the right skill mix on duty? If you're a district nurse, what was your caseload like for that day, and what was your experience? If you're in a care home or nursing home setting, how many nurses on duty were there? And were you able to give the basic care of repositioning patients and skin hygiene and health? Had we done a patient assessment that was holistic, or were the key parts that had actually been mixed? Was the care delivered actually linked to the risk assessment of the patient, or had there been a disconnect along the line? What kind of equipment was in use for pressure ulcer prevention? Was it in good working order? Had it been serviced? Had it been checked recently? And then also thinking about the wider things that are happening. I know many of you, like myself, will be spending most of your careers within acute hospitals, and bed capacity and how many patients are coming through our emergency departments can put a huge pressure on delivering fundamental care at the bedside with our patients to help prevent pressure damage. So a thought to start is, in your own practice, with your own team, in your own service, in your own organisation, if the fundamentals are not in place, why? What hasn't been happening? And what needs to be done by you and others to get those fundamentals in place? You might be sat here with me this evening and thinking, actually, we're doing really well. We've had a significant reduction in pressure damage in our organisation, and we're feeling pretty good about ourselves, actually, so we don't need to go through that stage. But if they are in place, how do you know it couldn't be better? How do you know that some of those patients that actually are coming through could have a better experience? And what's stopping you from looking at innovation to provide what else can be done? Now, I was a student nurse and I started back in 1987. And I'm just going to share this example with you from diabetes care. As I was working with the team here to develop this session, I was thinking about some of the changes that I've seen happen in my nursing career. Back in 1987, as a new student nurse, I was involved in being taught how to test patients' urine for the diabetic patients. And that was the only ability that we had at ward level to check how our diabetic patients were doing from a blood sugar point of view. Today, though, it's so different, isn't it? We have patients with implantable, closed-loop systems with a phone app monitoring their blood sugar levels on a minute-by-minute basis. I would never have imagined, as that student back in 1987, that this is how far diabetes care could go. And it really brings the experience back to the patient, that they can live a full, happy life where the control of their diabetes care is within their own hands. So what innovations have happened within tissue viability compared to other specialties? Well, I can think over my career, and perhaps you'd like to think over your career as well. Or maybe you're a student nurse and you're just at the start of your career within nursing. What are you seeing currently that maybe in 10, 15, 20, or in my case even more years, you might want to see for your patients? Because it is possible. We have innovated. So let's think a little bit about innovation in tissue viability. And I really encourage you to challenge yourselves on your own experiences through this next session. So through my career within tissue viability, pressure ulcer prevention has come a huge way, an enormous step forward. We've gone from the days where nobody was counting them, or areas were counting them but then not doing anything with the data. We've seen the implementation of sequence schemes, where we were actually obliged by our commissioners to count the number of pressure ulcers, bearing in mind this was just a prevalence audit. And now we have a national agenda which is driving forward the reduction in avoidable pressure damage. What an amazing journey pressure ulcers have been on. But it's not yet finished, is it? We still have work to do within this area. There are still organisations struggling within the NHS and the wider healthcare arena to reduce pressure ulcers to as low a level as possible. But wider in tissue viability, we still have many variations on wound management. From geographical area to geographical area, we have people seeing the same types of patients with the same types of wounds, but using different products to manage them. Leg ulcer care, diabetic foot care can be a bit of a lottery in the UK currently, depending on where you live and how those services have been commissioned and delivered. And one of my own favourite wounds, surgical dehiscence. For those of you that work in surgical environments or in post-operative care, how many of your patients are having breakdown of their surgical wound? And what do we do about it? Can I just pause a moment? I've got a message screen just come up, so I think we just need to press something. Wonderful. There. That was a good test of me on the spot, wasn't it? I was talking about surgical dehiscence. So how many of our patients have surgery, the wound breaks open, and we go back and do that root cause analysis to find out what has caused it. We do our incident reporting and we start to look at a picture of what may be happening and what we can do to improve surgical care. So consider yourselves what tissue viability and wound care, if you take a moment to think, and we'd really encourage you to post your thoughts. An example from my own experience was several years ago. I was involved in what was called the Your Turn campaign. This was before pressure ulcer prevention and monitoring was on the radar, before sequence. And a group of vested individuals came together across the UK and Your Turn campaign was launched. And again, it shared the same fundamentals as Stop the Pressure, and that it wanted to engage people to a culture change, to thinking about what they could do as their turn. I thought this was such a great example of what we could be doing to innovate the care in the organisation I was working in. So I sought out my chief nurse, I went to see my chief executive. At the time I was a band 7 tissue viability nurse, and it was a bit scary trying to get an appointment with my chief executive. But I wanted to share with him some photos and examples of what was happening in our organisation, and he was responsible for it. He really listened, as did my director of nursing, and she was an amazing support for us. We launched Your Turn across the organisation, and we saw significant changes in reduction in the number of patients developing pressure ulcers. As the agenda then changed nationally and our commissioners started to become interested in this as an avoidable harm, we were then really well placed when the first sequence scheme came our way, because we'd already got our benchmarking data, we'd already started to engage and educate people on what was required, and we were already starting to lead the field in our own organisation. Having thought about that, what could we do within leg ulcer care, diabetic foot care and surgical dehiscence in the same way? So who regulates us? Well, it's the Care Quality Commission is the regulator of health providers, and they have a, sorry, the word's just gone straight out of my head, a rating system, that's the word. And within that rating system, the two better ratings to achieve are good or outstanding. Now each year the Care Quality Commission undertake a significant number of inspections of provider organisations, and they publish their findings in a document called the State of Care. This was published last month in October. Again, I would encourage you to go and have a read of this document. It gives amazing examples of where things have gone from good to outstanding. Trusts that have delivered services, not just within wound care and tissue viability, where they felt that they were doing a really good job from a quality, safety, effectiveness and patient experience point of view, but they've moved into outstanding. One of the things that the State of Care document in October highlights is that more room and support needs to be given for innovations in care, and that it's those innovations that have helped those good organisations to move to outstanding. They also highlight two particular areas. And we hear a lot about leadership in the NHS at the moment, but what they found in those organisations was that leaders were found at every level, in every staff group, and that all of those people shared a vision for what the quality of care for their patients, residents and clients could be. And it was that shared vision that helped them to move from good to outstanding. I recognise at this point that we haven't considered the poor and the inadequate, but today's presentation is really about those of us that are doing really great and how we can move forward, and at the same time support our colleagues that need to move to a good position in the first place. So what makes a successful innovation? Across England, the academic health science networks have undertaken some research to look into what are the common themes of NHS organisations that have successfully innovated to improve quality for their patients. And they've come across these key themes. There's leadership, quality improvement technology and interventions, data measurement, documentation, a clinical focus and education. Leadership initially was prioritised at a senior level, so making sure that board members understood what was needed, what was the vision for quality of care for their patients, and that those senior level leaders were leading the way for the organisation, talking about it and doing it in practice. It was always based on a patient safety issue, so something that has been highlighted through root cause analysis, serious incident reporting or safeguard reporting. It was always led by a multidisciplinary team at a local level, because those are the people that are actually going to make those small changes but significant changes. And learning events were held to share that learning across the full organisation, not just the area where the innovation improvement happened. And most importantly, patients were involved in all stages. Quality improvement methodology was used, and examples of that include interventional rounding, safety huddles, recognising good as well as poor. So using root cause analysis to say, actually, this was really good practice, and we're going to share what is good practice through this root cause analysis, rather like the carrot as opposed to a stick from a root cause analysis that's gone wrong. So very small steps, but all part of the quality improvement cycle. Data. Oh, how many of us love data and what it can tell us? But it's important that we have it to get our basics right, and that the data is consistent and is measuring what we're trying to achieve. Sometimes we see a discrepancy in that. If we think about SI reporting, that's a fantastic point of data that we can use. But we need to be able to use it better, both for the good outcomes and the poor outcomes. And we need to use that data to help us learn as an organisation, so that our patients coming into every different part of our organisation can be managed in an equitable manner. They also found in documentation that it was simplified documentation. It was quick, easy to use at the bedside with the patient at the point of care. No point being off on a computer screen at the nurse's station where people can't access. Importantly, that the documentation was something that could be repeatably used by every staff member who saw or put their hands on that patient. And that everybody understood the clinical focus for why the innovation was taking place. And that leads back to it being a patient safety issue. I don't think any of us would challenge our line managers if they came to say to us, this month we want to focus on this subject area because these are the harms that have been happening to the patients in our care. And I can't underestimate the impact of education, both internally within your own organisation, but also outreaching to organisations such as care homes, nursing homes, residential homes, all of the places where you might have your patients admitted from or discharged to, so that everybody is a part of the whole quality improvement cycle. One example from the document was about preventing harm in an emergency department. It was undertaken by Dr. Emma Redfern in Bristol. And this was about preventing harm in overcrowded emergency departments, which is something all of us hear about almost on a daily basis. What she did was to undertook a review of all the serious untoward incidences that had happened within the emergency department, what had gone wrong when there was particularly overcrowding, and all of us will have walked through departments when they're under those kinds of stress. It showed Emma that there was a real theme of incidents occurring. So she developed with colleagues a simple checklist and an early warning score system that every member of staff could undertake. And over the period of time that they introduced that, they saw a 5% increase of CTs being undertaken within 1 hour for patients who came to the ED with suspected stroke. And as those of you that will know about stroke pathways, that early diagnosis is absolutely key to the treatment of the patient and the prevention of other associated complications from stroke. They also saw an amazing 25% increase of the early warning scores and hourly vital signs monitoring. And of all of this led to them having no clinical incidences relating to delays in recognising a deteriorating patient. They also carry this on when the department isn't overcrowded. So it's a consistent approach taken by the staff at all times. And if you look at the price tag, it's very, very small amount of money for the amount of change that they'd seen and the avoidable harm and increased quality of care for the patients through their departments. I have a number of colleagues that work within emergency departments, and I know the stress that they work under when it's overcrowded. So to know that through doing those simple reviews of serious untoward incidences, thinking about a simple checklist, educating all of the staff, undertaking early warning assessments really helped them to manage their patients from a quality point of view when they were under such duress. But let's think about barriers to innovation, because I'm sure many of you have tried to do things that are new. I certainly have many occasions. And sometimes those barriers can just seem completely insurmountable and they can take your motivation away. So what are they? While I'm talking these through, have a think, do any of them sound familiar? And please post your comments so that we can talk about them later. These are the main barriers of innovation that were found by the Academic Health Science Network when they were looking into successful adoption of innovation. The first one was around perception. So, is there actually a need to change? And linking back to our title, is good good enough? It might be that many of us are sitting there thinking, actually, we've reduced significantly in our organisation. So our perception of the need to do more might be slightly different to organisations that still haven't quite got on top of their pressure ulcer reduction targets. What about resistance to change? Well, actually, we're okay. And in comparison to some of our challenges in this organisation, pressure ulcers are just a tiny, tiny figure. What about if you're working in an organisation that is financially challenged, that is heading towards, as we career towards Christmas, with significant financial deficit by year end? Maybe you think, actually, if they're asking us to save money on paper clips, I can't go to them and talk to them about something that's innovative. Well, please do. What's the capacity within the organisation to innovate? Does your organisation have a history of it or a history of avoiding it? Is your organisation ready? What about the staffing who are going to do this and the time that it will take for you to do? And that brings us on to motivation. What motivates us to change? Is it a vision for what we want for our patient group? Is it a set of values that we hold as a team or an individual or an organisation? Maybe we're enticed or put in competition with a neighbouring organisation or trust, that their rates are better than our rates. Or maybe it's the threat of disciplinary action that motivates you to change. Please let us know your thoughts. The Wounds UK conference was held earlier this month up in Harrogate, and there was a really inspirational speaker there who has taken innovation into the teaching place. Professor Kerry Reid-Searle is from Australia, and she's a teacher innovator. She uses something called Mask Ed, which is basically masking the educator. She uses silicone props and the importance of keeping the patient at the heart of everything. And you can see pictures of Kerry, the top right and bottom left. So now some thoughts for you to consider within your own practice, both this evening and over the coming days and weeks. Why is it important for you in your own practice to measure pressure ulcer occurrence? How do you identify how well you're doing? Have you seen improvements or deterioration, or have you reached a plateau? Who do you have to tell about it, and why is it important to tell them? Do you trust the data? How sustainable are the changes that you've made or could be made? And how do you turn poor into good and good into outstanding? And how do you keep it there? And what happens next? Governance is a process that we use within healthcare to make sure that what we're doing is safe. And I'm not going to read this slide through for you, but pressure ulcer governance is equally as important as any other area of governance within healthcare. It's about essential standards, minimum standards being met by the organisation for every service it delivers. That the organisation is striving for continuous quality improvement, and that every member of staff is focused on quality, effective, safe, person-centred care. So what is QI? If you've been on NHS Jobs website recently, you will see that there are more and more jobs in QI coming out within the NHS. Well, I like to think about it in terms of assurance or reassurance. So I would be reassured if a nurse or a matron came up to me and said, Helen, on our ward, in our department, in our team, these are the results for our pressure ulcer incidents. And I might say, that's fantastic, that's great. But to be assured of that, I'd like to see the data, and I'd like to see the source of the data, and I'd like to see the methodology of how that data is undertaken and collected. So how do we demystify it? Because it is just another term. Well, here is a definition of what QI is. It's systematic. It uses specific techniques to improve quality. An important ingredient is it's successful and sustained in a way that makes the change introduced and implemented, and that it's a consistent approach that's taken. Another way of thinking about it, which probably is more to my style, is that it's a process that takes you through and helps you to understand that what you're doing is safe, effective, timely, efficient, equitable for all, and patient-centred. So think about this yourselves, your existing approach to pressure ulcer prevention. Are you taking true assurance or being reassured? What are you trying to accomplish? How will you know that any change that you've implemented is an actual improvement? And what changes do you need to make sure that that improvement is embedded and sustained in everyday practice by everybody? One of the simple tools within quality improvement is the Plan, Do, Study, Act. And this was spoken about very eloquently and enthusiastically back in February 2019 at the Wound Today conference by Jenny MacDonald, tissue viability nurse and Darcy Fellow at the Royal Marsden. She spoke about her story so far in relation to reducing pressure ulcers. And she took the audience through the Plan, Do, Study, Act model in relation to reducing pressure ulcer. I was at the conference, and at the end Jenny said, I'm not entirely sure exactly which thing we did right, but it was about every part of the quality improvement process. It was every part of it that was important, not one particular area. So again, ideas for you to consider. Do you need to go away from this evening and think about, well, actually, how do we diagnose what's happening within our team and service? Are we confident in the governance that we've got around pressure ulcer prevention? How do we support things so that they're sustained and spread across other teams? And what areas could we innovate to make ourselves from good to outstanding? Who can help you make changes? Because as we saw through our two athletes, it isn't just about individuals. Thinking about who has accountability for pressure ulcer reduction in your organisation, as opposed to who is responsible for delivering it. What about governance, risk management, service delivery? How does that fit in the organisation and their priorities for what they want to deliver? As a former chief nurse and a divisional director of nursing, make sure they're involved. What sort of support should you be asking them for? And do think about your agents of change. They may be not the usual people that you would go to, but very influential. So in summary, I'd like each of you to think, both as a person and a healthcare worker, what is your individual impact on every patient you see to prevent pressure damage? And what more could you do to take that patient's experience to the next level? Don't forget, we've made significant improvements in this area, both nationally and locally, and we must continue to forge forward with that. Think about the visibility and understanding of these, our contractual obligations, and making sure our boards are interested. Think about our performance, not just where it's been and where it is now, but what could it look like in the future? And how can innovation help us achieve that? And most importantly, make sure that everybody's involved, our patients and carers and their loved ones. So I hope we've challenged your mindset and made you think a little bit. We'd really like you to comment on what next steps you were going to take, and maybe write down one thing that you will commit to do. And based on your own current performance, where you feel you are delivering as a team, do let us know. We'll now move on to our real-time question and answer session. Remember, you can take part at any time by commenting on the video. So let's move on to our first question. So question 1 that has come in. We've been asked to stop collecting safety thermometer data at an acute trust. We feel this adds no value and takes time away from patients, and more reliable data is available. Why do we still collect this? What an excellent question from Leeds, my home city. It's still required contractually is the answer, I'm afraid, to that question. So we do have some disconnects nationally between what is expected by our commissioners of our services, what information they need to take assurance about the quality of our care. What I would suggest you do is speak to board level members of your trust and speak to commissioners and educate them on what reliable data is available other than safety thermometer. I'd start the conversations now because we're in November and they'll already be talking about the contract from April next year. So start to talk to them now about maybe running parallel reporting. So safety thermometer is showing you a point prevalence at one point in time, but actually your more reliable data, which I'm guessing is incident reporting, I'd ask them if you can run both concurrently, and that it gives them more governance, more assurance around that. So I hope that helps. Question 2. How do I start a conversation with my chief nurse or director of nursing, and what do I need to have with me or need to know before I approach them? This is one I really wished I'd known when I was a very junior tissue viability nurse, and then having been the other side as a chief nurse. The first thing I'd say is make sure they know you. Don't think about hierarchy. You are as important as anybody else, and anyone that says to you you can't go to your chief nurse or director of nursing, I would ignore them. Take your data with you and write down very clearly what your concerns are. Chief nurses, director of nursing, divisional directors of nursing are busy people with huge conflicting diaries and obligations. So be bright, be specific, and ask them what they are going to do to help you. But please go with some ideas. This probably won't be a subject area that they're expert in. So go to them and say, this is our data, this is what we need to do, this is what I want you to do. And good luck with that. We'll move on to the next question. Gemma. Hi Gemma, I hope you're well. Gemma's question is it ever okay to accept a pressure ulcer may remain static and may never heal in favour of improvement to quality of life and patient choice? Oh, this is a real head-heart question, isn't it? And certainly when we're reporting is one that we need to make really clear. My own professional experience is that there will be a group of patients where healing is not the expected outcome. And actually palliation of the wound, irrespective of the wound etiology, is both the best for the person and their quality of life, and possibly what they might have chosen as well. Let me just read your question through again. Is it ever okay to accept a pressure ulcer may remain static and may never heal in favour of improvement to quality of life? May never heal. So yes, I agree. I think we have to take every single patient as they present to us. We have to think about our holistic assessment. We have to think about realistically, is healing an outcome for that patient? It may be that we want to keep the wound static. We not want to, but our only option is to keep the wound static, and that we prevent infections from occurring in that wound, and we keep the patient free of pain and able to live a quality of life that they want to live. Thank you, Gemma. Good luck with your service. On to the next question. If we're currently meeting our targets and we feel that we are good, what could we look for as signals that it could be even better? Okay, so this is about going out and scoping what else is happening both in your region, nationally and internationally. I'm sure there'll be a member of your team, if it's not yourself, that loves going onto Google, that loves going onto search engines, that goes on to looking at agendas for conferences and international meetings. Have a look at those and have a look at what people are starting to talk about that might be innovative, that might be different. Some of those things you might think, well, this is a bit disruptive and it's not quite what we're used to doing. But have a look at it and think about, is that the step that you could take that would take you from good to outstanding? So you need to open your eyes beyond your own organisation and have a look at what else is going on out around. Thank you for question 4. Question 5, how do you maintain outstanding? Oh, this is a big question, isn't it? It goes back to the leadership, the strategy, and everybody understanding what their vision is for patient care. It's about everybody going to work every day thinking that they're going to and delivering the best for their patients each day. It's about maintaining that quality is the standard by which you do everything for every patient at every intervention. And if you can't, that you have a way that you feel confident to raise your concerns. Because sometimes it is really difficult, not just sometimes, a lot of the time it's really difficult in our day-to-day jobs. So it's important that you flag up the times when it isn't possible for you to do that. Question number 6, hello, third year student nurse. In your dissertation year, well done, keep with us. And prevention of pressure ulcers interests you and you'd love to base it on pressure ulcers. Do you have any tips on this topic? There is a world of information out there for you, third year student nurse. If you look on Wound Care Today's website, there is all sorts of online packages that you can look at. Mernlicher also have online packages. If you go into the library and do a literature search, there will be all sorts of articles that you can read. Probably what I would encourage you to do is focus on one area of prevention of pressure ulcers because it is quite a wide subject, and think about what you could do in that one area. It might be that as a result of today you're thinking about innovation and maybe start your literature search with looking at what is new that's been written about. But good luck, and I wish you a really great career as a student, as a nurse. It's a fantastic profession. Oh, we're at our final question. Thank you so much. So, I don't know who this is from, but the question is, how do we deep dive into non-compliance? 60% of our root cause analysis last month suggested patients non-compliant, and this worries me a lot. How do we effectively monitor compliance and drill the elements of non-compliance down? Okay, wow, that is a bit of a challenge that you've got there, isn't it? So, what I would go back to look at is the environment that you're working and the demographics of the patients that you're looking after. So where are those patients based? What is their background? And are there links between compliance and the demographics of the patient? So it might be that you're working in an area where there's a high level of dementia and that the patients just don't understand because the level of dementia that they have. And then I would start to have conversations about where does compliance come in and non-compliance, and how you can work with those patients that do have capacity to understand. And how do you document non-compliance within your organisation? You do need to think about safeguarding, and you do need to think about the person's capacity to make decisions for themselves. And drill down let me just read the question again. Drill the elements of non-compliance down. I have to say that you might not be able to do that if you've explored all of the reasons why your patients are non-compliant, you might not actually be able to reduce that 60%. But what you should be able to do is fully explore what that 60% is, what you've done about it and what you are repeatedly doing about it for every patient. Don't just give up the first time the patient says they're not doing something. You must keep doing it, keep advising them, keep reassuring about the health benefits of doing it, about their quality of life, and keep documenting it. Good luck. So here is our conclusion. Firstly, I'd like to say thank you so much for joining me, and thank you for the team that I've been working with today. This concludes our live training session this evening. Thank you so much for your questions and your comments. They've been really interesting to read. And we'll do our best to come back and answer any which we could not answer tonight. I'd like to take this opportunity to thank Mernlicher for their support for this event, and once again, all of the team here this evening. Your certificate of attendance can be accessed from our separate certificate website. The link is on the screen now and will also be posted and pinned in the comments to make it easy for you to follow it at the end of this broadcast. I hope this has helped you gain a better understanding of the challenges surrounding pressure ulcer management. If you've enjoyed today, please like and follow us on Facebook to make sure that you see all the details of future live events. Thank you so much for watching. Have a safe evening and good luck.